I'm going to talk a little bit about placental abruption and gestational diabetes, and I want to talk about cardio and metabolic outcomes. I know that the focus is on cardiovascular, but the clustering of metabolic disorders with cardiovascular disease is really important. And as I have come back to being regular faculty, which is a pure joy, and starting up my research program again, I've really come to this space of trying to really understand and motivate a more life course approach to women's health. So these are my disclosures, and none have any conflict with what I'm going to present today. And my overview, I'm going to basically not spend a lot of time on the stress test because you've done such a beautiful job already. But I am going to talk a little bit about placental abruption in isolation. It's a disorder of pregnancy, premature separation of the placenta from the decidua. It happens in only 1% of pregnancy, and I emphasize only, but it is a pure form of a vascular accident. And while it might be nice to continue to aggregate and look at APOs, I think it's also important to look at isolated, specific, phenotype-specific disorders. Placental abruption is usually combined with other adverse outcomes, fetal growth restriction, or IUGR, or SGA, and it's combined with preeclampsia and hypertensive disorders of pregnancy. And you'll see that I'll present both. I want to talk about gestational diabetes as well, mostly as the metabolic harbinger, and talk about kidney metabolic disorders. And if time permits, to show that we're even looking now with my postdoc at other outcomes, including cancer outcomes. And then mechanisms. I want to talk a little bit about mechanisms because observational epidemiology, I think, requires us to always look for other sources of data and information to allow for more solid inference of the observational data. And then just spend a little time talking about how do we go beyond just looking at cardiovascular risks, but maybe looking at metabolic risks postpartum as well. So I don't need to dwell on the fact that pregnancy is a cardiometabolic stress test. We know this. But I do want to recognize placental abruption as a vascular harbinger of risk, and that we could be looking at vascular organs like the heart, but also the brain, and accelerated vascular aging. And I'll come back to the accelerated aging hypothesis. But it's not such a stretch when we think about the early diagnosis of multiple chronic disorders, which is sort of a clinical risk marker of accelerated aging, right? Multimorbidity is really the old-fashioned clinical marker of accelerated aging. These are some early studies published, before 2013 that really started to bring people's attention towards placental abruption being a significant risk factor for long-term cardiovascular health. The first one on top showed that a history of placental abruption was associated with a 4-fold increased risk of cardiovascular mortality. Another study showed after 15-year follow-up that all-cause mortality increased 2-fold. And again, looking at other sources of data, mothers with abruption, complicated pregnancies had persistent blood sample biomarkers of inflammatory biomarkers as well as dyslipidemia and hypertriglyceridemia 6 months postpartum. We didn't have this kind of data available to us at the time, so my colleague Ananth, then at Columbia, looked at the Danish cohort of about 13 million person years of women who had one or more delivery, of which there were 11, almost 12,000 complicated pregnancies by abruption. So we had a nice long follow-up and a lot of person time, and we were able in this cohort to show that the adjusted hazard ratio for developing cardiovascular disease, morbidity was 1.5-fold with a fairly tight confidence interval with a sample size like that. And you can also see the mortality, cardiovascular disease-related mortality, elevated almost 3-fold in this population. So coming back, feel like coming back to school, I had an opportunity to say, well, okay, we pretty much have shown the placenta-heart connection. How about the placenta-brain connection? And we first thought we would take a quick look looking at the NRD database, which is the National Readmission Database. And this allows us to look at readmission of women who delivered a pregnancy within the year of the pregnancy. And so it's a very short-term follow-up, but we thought if we saw a signal here, then we could go ahead in building a database that would allow us to have 28 years of follow-up. And we actually have built this, or are in the process of building it, and hope we can get the grant funded to really have fun with this data. But in this pilot study of 17 million pregnancies, admissions followed over a year, we found that the risk of any brain disorder, which would include strokes, epilepsy, neuropsychiatric vulnerabilities, you could see any was associated with a 50% increase in risk, the hazard ratio being 1.5. And that's any brain disorder hospitalization within a year of delivery. We also found an interesting dose-response relationship. So for example, if there's one of the three conditions, either an abruption, SGA, or preeclampsia, the risk was 1.39 for any brain disorder. When a woman who had comorbid condition or three of the conditions, the risk increased. And I think that adds a little bit of reassurance that we're seeing this kind of comorbid increasing risk and non-isolation. We also did want to look at the independent components, and we found that preeclampsia alone had the highest isolated of the conditions for stroke and for epilepsy. And this is fairly consistent. This is what we've seen in other Nordic and Northern European studies. Abruption alone, which is a novel observation from this analysis, is there's evidence of it being an independent predictor of neuropsychiatric vulnerability and disorders. And that fetal growth restriction alone was associated with a 35% increase of psychiatric and neurological conditions. So going back to the literature, we wanted to see, are these epidemiologic associations supported by other sources of data? And I'll come back to that, but we also looked at effect modification in this analysis, and we saw that brain disorder hospitalization became progressively higher with advancing maternal age up to age 35, suggesting that ischemic placental disease may actually be unmasking brain aging in a young reproductive cohort, and that the lifetime burden of these brain disorders might actually be quite profound. And that's why we're very excited about looking at 20-year follow-up of pregnant women with these conditions. I want to go back. So the clinical gap here, and I think if we are able to replicate these findings in independent samples, the guidelines recommend cardiovascular follow-up. We've heard that after hypertensive disorders. But maybe there is an opportunity here for recommendation as the evidence comes in and becomes more robust for neurological follow-up after ischemic placental disorders. And Virginia described a junior faculty member or a fellow here who is actively working in this space, and I think it's just brilliant. It's wonderful that we would be thinking about the vascular bread that has not really been fully understood and studied in midlife women and women who have a history of adverse outcomes. So, always looking for corroborating evidence, right? And here I want to just briefly talk about a study published in Hypertension last year, 1,400 Paris women, 30 years of follow-up with a mean age of 55 years. And you could see there was lower or worsening cognitive function, such as processing speed, verbal fluency, and executive function at midlife among women with a history of gestational hypertension, and almost a 5-year decline in the processing speed and in executive function. And there was also physiologic evidence of greater white mass in the parietal lobes. For preeclampsia, the investigators found that there was a greater than 5-year decline in delayed verbal memory. And that pattern resembles really what would be cognitive impairment related to impairment of the vascular system. The key insights from this study are that gestational hypertension and preeclampsia may have distinct, maybe distinct entities with different pathways for brain injury, and that there are different cognitive domains that would be impacted the different regions of the brain. I'd love to see this study replicated because there, again, the implications, the medical implications, the implications for brain aging being identified earlier in life would be a very powerful message and opportunity for prevention. There is an EVA study that I discovered in the process of understanding and interpreting our epidemiologic findings that I really feel that we have to replicate this. The EVA study essentially found that there was a 9.2 greater odds of EVA being early vascular aging in severe preeclamptic cases versus controls. Again, underscoring and maybe highlighting the pathophysiological mechanism that would undergird the epidemiologic observation. They also reported using a non-hemodynamic evaluation greater evidence of aortic stiffness and increase in central blood pressure and steady arterial load and arterial wave reflections of women with prior preeclampsia. And they found a dose-response relationship. So the more severe the preeclampsia, for example, early onset preeclampsia with preterm birth, and women with recurrent preeclampsia had progressively more significant conditions, outcomes of interest. And the implications here, again, are that the mechanisms are relevant to the entire spectrum of impaired ischemic placental disorders, including abruption. I want to switch now to the harbinger of metabolic conditions. And I'll briefly talk, I won't talk too much about type 2 diabetes after GDM. I think many of us know that literature. But want to talk a little bit about fatty liver disease and cardiometabolic liver syndrome, and then perhaps have time to just show you some preliminary hypothesis-generating data looking at a history of GDM, possibly telling us something about cancer risk, particularly hepatic risks, gastric disorders. What I'm showing you here is a study that was recently published just last week, led by my postdoc, Larry Liu. And he used the market scan claims data to create a cohort of 1.3, almost 1.4 million pregnancies. And in that cohort, we found, using ICD-9 codes, a prevalence of 8.4% GDM, which is likely an underestimate of gestational diabetes. Again, very important preliminary data for the work that I will show you. So the design of this study is a retrospective cohort using commercially insured pregnancies between 2007 and 2023. And we restricted or designed this cohort for women who had a pregnancy lasting at least 20 weeks gestation and were continuously enrolled in their insurance plan for greater than 90 days before pregnancy and greater than a year after pregnancy. And the outcome is incident recorded postpartum diagnosed type 2 diabetes in the claims data and MASLD, a form of fatty liver. The length of follow-up was up to 15 years, and we used Cox semi-Markov multi-state modeling to do something that I think was the first time done in this kind of work. First, the overall finding, not surprising, a history of gestational diabetes associated with a very large, almost a 12-fold increase risk of developing type 2 diabetes. This has been repeated over and over and over again. And sadly, I don't think we do enough postpartum screening and prevention in this group. We wanted to look at a diabetes-related, metabolic-related adverse outcome, MASLD, and you can see women with a history of gestational diabetes, their hazard ratio for developing fatty liver is 2.3, almost 2.3-fold. Now, we wanted to understand what is the relationship of going from gestational diabetes to type 2 diabetes to MASLD. And so Larry decided that he would use a multi-state model to essentially calculate the risk of type 2 diabetes given gestational diabetes is 12-fold. A strong increase in type 2 diabetes risk. And the question then is, we find a 2-fold increased risk for liver disease. Now what happens if you have GDM, but you prevent type 2 diabetes from happening? The risk for fatty liver goes essentially null. What does this tell us? This tells us that we might have an opportunity to prevent GDM-related fatty liver disease if we're successful in preventing type 2 diabetes. We did a counterfactual exercise to try to make this more accessible. The question here is, in the process of looking at the incidence of MASL 5 years after a pregnancy, if you did not have gestational diabetes, the risk for MASL would be a 0.45%, the excess risk, right? But if you had GDM, 5-year risk for MASL is 13.3%, almost a 30-fold increase for the type 2, for the GDM case versus the non-GDM case. Now the 5-year MASL risk, if you prevented type 2 diabetes completely, you would have almost baseline, 0.93% excess risk of MASLD. What this essentially says from this model-based idealized scenario is 96% of excess MASLD risk associated with GDM could be averted by preventing the progression of GDM to type 2 diabetes. And so this could add quite a bit of an incentive for screening and managing this glycemia early in women who are on a very clear path for developing type 2 diabetes. And this could be done with interventions we already know: structured weight management, physical activity, pharmacologic interventions, maybe low-dose metformin, for example, or GLP. And that integrating postpartum care spanning obstetrics, primary care, endocrinology, and hepatology, as well as cardiology, might be key. But the most important thing is that handoff, which we've heard from the speakers earlier. We've now started to look at a variety of other outcomes, just to make the point that glucose screening alone would be insufficient for managing the risks that women with a history of GDM have. And I'll just allow you to, take a look at these associations. The composite metabolic disorder risk is a twofold increase for women with a history of GDM. And then for cardiovascular, there is a cardiovascular risk in relation to gestational diabetes history. Larry's also taken the initiative of looking at what we might learn about cancer onset, particularly early cancer onset, which we know demographically is increasing. The prevalence of early onset cancer is increasing quite markedly in the US. And so Larry restricted his analysis to look specifically at early onset stomach cancer and identified a 2.1-fold risk associated with a history of gestational diabetes. And you can see the other risks here. It was the MASLD association, where we know fatty liver disease is an important risk factor for liver disease, hepatic carcinoma, that we went down this path. This hypothesis generating is likely to, if we are able to replicate these findings, could be another argument for extending the clinical significance of gestational diabetes beyond the cardiometabolic domain, and to really think more about understanding metabolically related early onset cancers. Again, coming back to understanding mechanisms that might explain these associations. This is a study done with my collaborators at the National University of Singapore. And here we looked at 178,000 women, UK Biobank data. The exposures is self-reported and hospital record gestational diabetes history, and our outcome was looking at phenotypic age, or pheno-age, acceleration using 9 biological markers. And we have follow-up of this population for 12 years for mortality and for cardiometabolic disease. And the key finding here is gestational diabetes being associated with an acceleration of pheno-age by 2.34 years. Just in the interest of time, I'll go to some additional pathophysiologic mechanisms. And I wanted to show here, I love this study. I told Virginia that, when I saw this study, it's what we needed. And I know that it was beautifully designed. It's a hybrid. And this is a perfect example of what you do with what's available. And I think what's really important here is identifying these protein signals across the postpartum and midlife that really supports the epidemiology studies and the results that we might find from imperfect, but that's all we have kind of data. And when you put these two together, you are starting to build A-level evidence. There's a point that I don't think has been made yet in this amazing symposium, and that is pregnancy itself, whether it's complicated or uncomplicated, may accelerate aging in women. And I think this is an important point that we should contemplate, not just look at APO-related pregnancies, but look at pregnancies as another predictor of what happens to metabolic aging, okay, in women writ large. This is a study that used the data from the Philippines. It's published in PNAS. Most of us probably wouldn't be looking there for this kind of paper. But I recommend you all read it, because what they found was gravidity, accelerated aging across 6 methylation DNA clocks, aging clocks. And that acceleration went from 2 to 14 months for each pregnancy. And you do the negative control. The negative control was looking at the male partners of these women, of course. And as you'd expect, the negative control was null. There's another study, not quite as meticulously done, but corroborating a 2-year aging per pregnancy, and this is the Pinelli paper. Cellular senescence. I like to think about accelerated aging and cellular decline. So the cellular senescence data reinforces the observational data, again, where you see women with a prior history of preeclampsia having these biomarker signals that are consistent with early aging and cellular decline. So there's a converging set of mechanisms that underlie or support the observational data that we're seeing. We're seeing evidence of endothelial dysfunction. We're seeing evidence of chronic systemic inflammation, beta cell failure, neuroinflammatory markers, and epigenetic reprogramming. And then finally, putting that all together where you see a documentation of cellular senescence. There is a lot of evidence now available that supports understanding accelerated aging and the acquisition of age-related disorders in pregnancy. But there's still critical gaps that need to be filled, and I think a gathering like this really helps focus those of us who are committed to filling these gaps to think about them. So I'll just quickly go through. I love the placenta too, Virginia. And I don't know, can I share the story of how your husband says yes. You should? So Virginia's husband says that the introduction, the one-line introduction for introducing her is that she is the Beyonce of the placenta. I don't know, I would be competing with you for that title, so I need to talk to your husband. But, the placenta is so understudied still. And I think this particular condition that is definitively a vascular disorder of the placenta, this infarction of a placenta, kind of like a heart attack below the waist, needs to be studied more carefully, right? We also need to push for unmasking or inducing. Maybe it's both. You've heard talks where the allowance is for both of these to be the truth. It would be important for us to know if it's unmasked or induced, because the approach to prevention might be different. The approach for surveillance might be different. We need more effort put towards neurological follow-up. We know that depression is quite ubiquitous in this population, particularly with the traumatic pregnancy. But we should know what normative neurological follow-up, it looks like in women with pregnancies. GDM surveillance, I would argue, with the evidence that's already available, is too narrow, and that we should be doing postpartum screening that not only looks at glucose, but extends to blood pressure, lipids, weight, and maybe even liver enzymes. And that, wouldn't it be great if we had another WHI? And then health equity, because we know that racial and socioeconomic disparities in the downstream morbidities are poorly characterized. So research priorities, lifespan risk models, intervention timing needs to be worked out. Mechanisms, always, I think, combining pathophysiologic evidence, the multi-omics evidence with the epidemiology evidence is critically important. And then, of course, equity research, critical. For clinical practice, expand postpartum surveillance of GDM, develop neurological follow-up after ischemic placental disorders, integrate pregnancy history into lifelong risk assessment, and I know that's what you're doing, and I cheer you on in making this happen, Megan, because we really do need better risk calculators for midlife women for cardiovascular and other diseases. And I think I'll stop there because, again, expand the EPOC study to abruption, if we could, and even look at gestational diabetes, because if we can tease out the gestational diabetes metabolic disorders, sequelae, we could go a long way with the tools we have for really driving prevention. And then policy implementations. There you go, Megan. I think you're on the right track in wanting to modify these risk scores. We've known for too long that these risks for cardiometabolic diseases are elevated in women with pregnancy, but we've gone for too long without scores that are specific to this population. And then the handoff has to be more than words. I think we really need to think about continuity of quality care. And women should never be told the pregnancy's over, your hypertension is gone, your pregnancy's over, your glycemic control is back to order, because we know that's not true academically, but it's not practiced sufficiently to protect and preserve and promote the health of these women. So, placental abruption and gestational diabetes are not transient. They are among the earliest and most powerful cardiometabolic harbingers available in clinical medicine. Their biological footprints persist for years in the genome, in the proteome, in the vasculature, in the brain, and in the clinics where these early disorders are diagnosed. And if you follow the statistics, when we talk about APOs, adverse pregnancy outcomes, we're talking up to 1 in 5 women. That is not a small group. It's at least 10% and as much as 20% of women who experience adverse outcomes deserve better and more multidisciplinary follow-up. I think this is an audience that knows this, that pregnancy is a window. And it's a window, maybe the earliest window that we have to identify and intervene. So the challenge really is to try now to close the no-do gap. How do we take the evidence and put it into clinical action? And I just want to thank a lot of my colleagues here, key colleagues here at Stanford, those at Rutgers, those at Harvard, and my students and postdoc who are a part of this rebuilding of research. Using real-world data is new for me, but I think it's an important additional data resource that we have to make use of, given the fact that we don't have an ongoing WHI, which I wish we would really motivate our administration to support a new one, because it's time that we build on that knowledge base. Okay, thanks for your attention.